changed much since then. So since we came out with the recommendations in December, I think 21. I have no conflict of interest to declare, apart from the fact that my views are not personal and are based on a consensus. I'll talk a bit about patient contact shielding, about the European consensus statement, and then go through each of the recommendations and maybe give some rationale in the time that I have. So just say that this is quite a sensitive area, and it's very important that we have consistency. We're all very well aware that the public perceives effects from radiation in many different ways. So, for instance, we would have the three-eyed fish from The Simpsons, but these have also more serious ramifications for staff. And this is a case of a radiographer who was lost a registration for many reasons. But one of the reasons cited was that they didn't give the mother a lead apron during the exam. So you can see how that different professional interpretations can have implications for the staff. So it's very important that we have a consistent and we are aware of the implications of whatever recommendations we make. And actually, I have, last year, we gave a presentation here and we had a pros and cons, and I see Mark in the audience there. I've asked his permission to use his image just before he got on, but it's very important we have debates like this because they're a really useful form of communication, and because we need to we need to also put this in context. Like, shielding is just one part of risk control, and here we have a classic risk control diagram of the hierarchy of controls, and this applies to patient radiation protection just as much as anything else. So we have elimination, which would really center around justification. We have substitution, which would be non-ionizing alternatives. We have engineering controls, which would be technology and optimization, administrative controls, which would be education, training, and policies, and the last thing we have, which is the least effective, is personal protective equipment. So this will apply to any scenario, and patient shielding is personal protective equipment. And common themes will appear about the use of shields. The potential, some drawbacks are the potential for artifacts to appear in the images, the potential to obscure clinical details that are the purpose of the exam in the first place, the potential to interfere with automatic exposure control inside and outside the field of view. And I think there's some more papers seen, even 5 to 7 centimeters outside the field of view in CT, we can still get interference with automatic exposure control. And between topograms on and off with the shielding, we have to be very careful. And outside the field of view, we get less, some small dose benefits possibly, but even smaller risk benefits. And we still have the potential for artifacts in CT. So we really need to understand our technology and where the beaming and image and data acquisition exists, and what happens with the technology we're using. So based on these, we've heard that a number of papers came out really starting around 2009, and then these developed into professional recommendations, and towards the end of 2017 to 2020, there was a number of different recommendations, but there was no European statement, and we were asked to really, have some sort of consistent European policy, and I think myself and John Damalakis wrote this invited commentary at that time. So we formed the GONAD and Patient Shielding Group, and the two aren't mutually exclusive, but it's a nice acronym when we talk about gaps. And the aim was to produce a consensus document on a number of types of patient shields. And we're very lucky to have access to some of these documents about how to write a European template for a consensus, which is applied to many areas of medicine. And there were some really good examples in the literature, say from the Heart Rhythm Society and Cardiology. And we really didn't want to reinvent the wheel. We wanted to build on what had been done already and learn from what had been done. We did look at some newer papers and considered them in detail, whether they would affect our consensus or not. We wanted something that was simple and clear to use. And for those who had been at the session this morning, we would have heard Claudio Granado talking about the need for unambiguous language in recommendations that can't be overly academic or detailed, that leaves a lot of room for ambiguity. We were very lucky to have a patient representative, Eric Briers, to inform us. We also recognise that this is a sensitive topic, and for some people it's how they communicate a good culture of radiation safety. So you guys in radiology and radiography, you make the invisible visible, and radiation safety culture is also invisible. And by giving somebody a lead apron or shield, you can, communicate that you care about them. But you've got to think how that is in the overall aspect. And also, it's based on assumptions. The recommendations are based on assumptions that, the technology was what we were aware of in Europe, that the cultures, the optimization, the quality assurance and all that, we were assuming that had been done, as part of normal everyday, which may not be true for even within Europe, and it may not be true for the rest of the world. So that's why we need to look to the IAEA and ICRP and these for more international groups. So these are the bodies involved in radiology that came together, and this shows you the importance of being involved in projects like Eurosafe, because we all would have known each other and worked together, and we all are aware of our roles and limitations, and we had a very good atmosphere in our group. And here's the people, and some of them are in the audience today, and I want to thank them for the contribution. So we used a traffic light system of red, green, and yellow, but some people are colorblind, so that's why we had to use a diagonal stripe for the red. I think red and green is particularly the problem, the males more than females, apparently. And then we used this to say whether we'd recommend things or not. And the majority of cases, we did not recommend shielding. So, for instance, gonad shielding, it was not recommended. It was felt that although there may be some small absolute dose reductions, the benefits versus the risks were just not there. And actually, some of the shields I'm showing in this slide aren't even commercially available anymore, such as those capsular shields. However, in dental radiology, where you may get primary beam impinging on the sensitive organs such as the thyroid, and particularly the prevalence of wide collimation and lack of rectangular small collimation, you get no benefit from irradiating that organ. So in those cases, you would use a thyroid collar to protect the thyroid. Likewise, in cone beam CT, you get some scatter from the machine into the thyroid, and we would have recommended shielding in that case. To protect the fetus, although you get, again, some very small differences in absolute dose, the benefits are, the risk benefit is not really affected by it, because you're mainly dealing with internal scatter, and I think you'll see some papers from Bigano and et al. That will talk about the fact that you can still have these interferences outside field of view in fetal imaging. So it is not recommended in those cases. Likewise, in the case of the eyes, again, the potential for artifacts, and we didn't find any real benefit in those cases. We did not recommend it there. Likewise with breast shields, and I think there's even been some papers about the potential again for small dose benefits, but the actual in the overall sense, we don't feel that it still is something that we would recommend. We do recognise, and we did in the group, that there are cases where patients, with the professional autonomy that you will be required to use shielding, whether it be for the technology, whether it be for that the patient won't go ahead with the scan, but it's very needed, in terms of consent. So we had, you need to be aware that when you inform the patient, you also have to tell them, if I'm giving you the shield, it may not produce any benefits, but it might interfere with your ability to get the clinical result that you want, and it might need to repeat examinations. And we need to know that we store the shields, we do quality assurance on the shields, that we clean the shields, that we lift the shields. So there's a lot of things to be considered there. So to summarise, we only recommended in routine practice the use of shields in dental radiology, and we produced them across the 3 journals in December 21 to really reflect the parity of esteem between professions. And I think that worked very well, and we're very appreciative of the synchronicity that we brought to that. So just to summarise, I'm here to talk about the GAPS group and where we're at the moment. So we wanted to make a European consensus statement, and really based on a patient perspective. We wanted to build on previous statements. We believe we've delivered something that's clear and easy to use. We do recognise that all of these things are recommendations that need a period for review. they need guidance for exceptions, and they need to reflect professional autonomy. So we believe we've arrived at one stage of our journey, and the next stage is to communicate it with professionals and patients. And I think Claudio is going to talk about a survey to see where it is at the moment. So I think we're at the 50% rate. So let's see where we are as time goes on. So we also really would like to encourage you to do research into new shields and new technology and how they combine. So we have produced a consensus document, and we realise there's challenges and limitations to overcome. So thank you very much.